Sayuran dan buah-buahan adalah sumber serat dan vitamin yang sangat baik untuk kesehatan pencernaan. Meski kaya akan manfaat, masih saja loh ada orang yang tidak suka makan sayuran, terutama anak-anak. Kurang mengonsumsi sayuran ternyata bisa berdampak buruk terhadap kesehatan usus kita loh. Bahkan sejumlah penelitian membuktikan bahwa jarang mengonsumsi sayuran bisa membuat seseorang berisiko terkena kanker usus besar. Berikut penjelasan Dokter Grace Tan dari Farrer Park Hospital Singapura terkait penyebab, faktor risiko, gejala, dan pengobatan kanker usus besar.
Fecal cancer is more common than stomach cancers and it causes more deaths worldwide. And if you look at this list again, in Indonesia, colon cancer tops stomach cancers and being the 6th most common cancer in Indonesia. So how does colorectal cancer start? What we understand is that it actually develops over many years and it usually starts off as a polyp, and then over time it grows and becomes cancer. So there are different types of polyps that you might want to understand. So the first is called hyperplastic polyps, and in these generally they have no risk of cancer. However, the kinds of polyps that we are worried about are called adenomas. And again, there are different types of adenomas with different risk of cancers. However, all types of adenomas should be removed because they all have a chance of growing and becoming cancer. What we understand is that in the general population, the number of patients that would have polyps are usually in the range of 15 to 25%, so pretty high. So this again is a picture that just depicts what is happening. So this is a polyp inside the inner lining of the colon. It can be really tiny, and over time, and usually we believe if over 10 to 15 years, this polyp can grow. And it slowly grows, and then eventually, because of some sort of mutation, it then transforms into a cancer. And as these things, if the patient doesn't come to seek help or doesn't even realize that it's there, then it continues to grow and eventually can then start to spread elsewhere. So this is a sort of a picture, sorry, it's a little bit blur of colonic polyps and on the scope. And the reason why, one of the reasons why we believe that polyp then develops into cancer is because every time we do a surgery to take out a colon cancer, very often we would actually see polyps around that cancer. You can see the cancer in the middle, you can see polyps at the side. So, you know, this sort of suspicion that this was probably a polyp to begin with and then grew into cancer, and this is how the theory started. So why does it develop and who gets it, right? So I think many studies have shown that the reason why we develop polyps and then finally cancer is because of many different kinds of mutations along the way. But we don't really know exactly what causes these mutations to happen, but it's probably a multifactorial, meaning that it could be due to, at one point it could be due to something you eat, at one point it can be due to something that you're exposed to in the environment. At another point, you know, it could be due to your family history. So different things occur, and all of them lead to the cancer. So we go back to risk factors again, and just like in stomach cancers, you know, if you do have one of these risk factors, it doesn't mean that you will get colorectal cancer, but it just means that you have probably a higher chance of having it. So things like age, so the older you are, we used to believe, we believe that you would have a higher chance. But I think that concept is changing because of the fact that we're seeing so many younger patients with colon cancer. Sex, meaning males or men are more common, are more likely to get colorectal cancers compared to females. A family history of colorectal cancer, if you have a first-degree relative or many second-degree relatives who have cancer of the colon, will probably also be at higher risk. And of course, if you have a personal history of other cancers, like of the ovary, of the uterus, or the breast, that also puts you at higher risk of colon cancers. If you have a history of colonic polyps, like we mentioned, that definitely puts you at higher risk of having colon cancer. And if you have certain conditions that we call inflammatory bowel disease, where you have chronic or long-term inflammation happening inside your lining of your intestines, you also might have a higher chance of having cancers. We know of two sort of hereditary conditions or conditions that run in the family that put you at higher chance of having colorectal cancers, and that is what we call FAP, or familial adenomatous polyposis, or HNPCC, which is non-polyposis colon cancer. And of course, there are also lifestyle factors, which we'll elaborate a little bit later. But just to illustrate, this is what FAP looks like. And on the scope endoscopy, you see many small polyps. And in these patients, it's not possible to remove so many polyps endoscopically. And actually, these patients are recommended to have a surgery to remove their entire colon before they hit the age of 30. Because most of these patients, or 100% of these patients, will develop colon cancer at some stage in their life. So we take out the colon in order to prevent it. So I mentioned lifestyle factors. So I think what a lot of research, and I guess most of this research is done in the United States and in Europe, it has been shown that a diet that is very high in red meat, in processed meats, like canned meat, because of the presence of sodium nitrites, they do have a higher chance of resulting in colon cancer. And in patients who do not eat lots of vegetables, fruits, they also have a higher chance of having colon cancer. Exercise and activity in general has also been shown to be associated with colon cancer. And the last two things would be smoking as well as obesity. And that's generally, I think, we know in the United States. So, you might ask yourself, yeah, I don't have any of those risk factors, but could it still happen to me? And unfortunately, the answer is yes. And I think that we all have to be very aware of the symptoms, because a lot of times, I think the reason why patients are diagnosed late with colon cancer is because they don't know what are the symptoms to watch out for. And only after many weeks, then they go and see a doctor and then get diagnosed. So I think always be aware, firstly, that colon cancer can present with bleeding in the stool. We call that perorectal bleeding. A change in bowel habits is something also commonly said by doctors. And what it really means is that if your usual bowel habits is going to the toilet once a day, but all of a sudden you start to go twice or 3 times a day. Or the other way, the converse is that if you actually go to the toilet once twice a day, but suddenly you start to go only once every 2 days. So that's what we term, and could possibly be constipation. So any change in your own bowel habits is what is important. The other thing is that the feeling that the bowel does not empty completely, where you feel that after going to the toilet there is incomplete. You still have stool that you can't pass out. That might be a symptom of a growth that is preventing stool from coming down. The other thing is that stools which are different in size, because if you do have a very low cancer or low growth, then what happens is that when the stool gets to that part where you're trying to pass out, it gets narrowed, and what we call pencil thin stools come out. Other things are like loss of weight or loss of appetite, which are generally, of course, harder to be sure about. But I think that if you don't intend to lose weight, you aren't on a diet, you're not exercising a lot, but you just lost weight for no reason, or you're not eating well, that's something to worry about. Other things are like frequent tummy pain, frequent gas, fullness or cramps. But I think we also are aware that a lot of patients do not have symptoms when they have colon cancer. So that's where you have to be very cognizant of that, and that's where the colorectal cancer screening comes in. So screening is a term that we use to describe looking for cancer when in patients who are thought to be healthy. So you don't have any symptoms, you feel fit and healthy. You might even be of a young, you might be less than 50 years old, but yet in these patients, it has been shown that they still can develop colon cancer and even stomach cancers. And so that's where screening comes in. We actually actively look for it at an early stage so that we can treat it and reduce the poor outcomes. So in this study, it has been shown that if in patients who underwent cancer screening, compared to patients who didn't, their survival was much better. So cancer screening does work. So there are many different ways that colorectal cancer screening can be done or are available in different countries. So one of the ways is a fecal test. So it's a stool test where you take a little bit of your stool and they look for blood within the stool. So that's either called a FIT test or FOBT test. And that's something that you can usually get from your local GP. But there are quite a lot of disadvantages of doing this fecal or stool test. I think the only advantage is that it is low cost and it can be done at home. However, there are a lot of disadvantages, like you can get a lot of false positive results. That means that you actually do pick up blood in the stool, but when you actually go for a proper test, there isn't any abnormality found. And other things are like, if you do have blood in the stool, you would still need to go for additional procedures like a colonoscopy to confirm whether there is anything in your colon. Other tests that you may be familiar with would be a barium enema, which is an X-ray test involving the contrast barium, where it's inserted into the backside, and then the barium is injected. And what we're looking for is again, similar to the stomach story, where you're looking for a narrowing in the lining of the stomach, of the colon, sorry, in this case. And then there's something called a CT colonoscopy or virtual colonoscopy, where you undergo a CT scan, but they're able to see and use sort of 3D or IT techniques in order to re-image your whole colon. The thing about these two is that even if you do find something on the imaging, the negative thing is that you would still require a proper colonoscopy in order to locate that thing that you see and take a biopsy. So I would say that the gold standard or the best way of screening is still an endoscopy. There are two types of endoscopy: a sigmoidoscopy, which only comes to this green line here, which is probably 1/3 of your colon, or a full colonoscopy, where we aim to get to the right side of your intestine and we see the entire colon. So this is a picture of the inside of your colon, and everybody's colon looks the same. And this is what a normal colon looks like. So a scope, which is a small tube with a camera at the end, is inserted through the back passage. Usually it can be done again under sedation, and it's a day procedure. So this is an example of a polyp that we see on colonoscopy. And the most amazing thing is that actually during the endoscopy, we can remove this polyp through the same procedure. And by removing the polyp, we actually reduce the risk of cancer, because now if you don't have the polyp, it would not be able to turn into cancer down the road. Unfortunately, when we do scopes, we do see things like this, where it's an obvious growth, and this is very suspicious of cancer. And here you can even see that there is some bleeding going on. And what we do if we see something like this is that we take a biopsy and send it off to the lab to confirm what this growth is. The other thing about doing a colonoscopy is also we'll be able to assess if you can pass through. So you see here, you can still see beyond this growth, and you can go in. However, in this case, it looks like the hole is actually really small because the growth or the tumor is growing around the entire colon. So in this case, this patient will be a very high chance of causing resulting in a blockage soon. Like mentioned, a colonoscopy is a day procedure. Usually on the night before, you're given what we call a bowel preparation, which is probably the part that most patients don't like. You drink this liquid, and then you will be going to the toilet at least 5-6 times in order to purge and to cleanse your entire colon. It's important because if you don't have a clean colon, when we do the endoscopy, we may not be able to see all the internal lining of your colon, and so that it's not so sensitive. But if it's nice and clean, we can see very clearly. We'll be looking for the polyps, and if we find a polyp, we can remove the lesion, we can remove the polyp and send it off for testing. So you might be asking, so when should we consider doing a colonoscopy? And I think it really depends on your risk. We would say that patients who have those hereditary conditions like FAP or HNPCC should have the colonoscopy when they're quite young. In FAPs, in their teens, and for HNPCC between their 20s. However, if you have a sort of increased medium risk of having colorectal cancer, And that means you have either a first-degree relative or you have 2 or more second-degree relatives. Then you should have your screening colonoscopy at the age of 40, or if your relative had cancer when they were much younger, then 10 years before that relative's age. In the average risk group, which is the general population without any of the risk factors, then there are certain guidelines. Like in America, their Cancer Society actually recommends screening to start by the age of 45. And I think that has recently only come down to 45. Before that, it was very similar to Singapore, where our guidelines is to start at age 50. But I think increasingly we are realizing that younger and younger patients are getting colon cancer, and so screening really needs to start much earlier. If you went on the internet and you looked for screening for colon cancer, you might find that there are different guidelines available. And generally, there would be guidelines to recommend either doing a stool test every year, and if it's positive, then go for a colonoscopy. The other would be doing a sigmoidoscopy 5 to 10 years, with the stool test in between, or doing the barium enema every 5 years, or colonoscopy every 10 years, or virtual colonoscopy every 5 years. So it's really quite confusing. But I mean, as I mentioned, I think the gold standard is probably to do a colonoscopy. And the good thing about it, as you see here, is that if your colonoscopy is clear, you don't find any polyps, you don't find any growths, then the next time you need a colonoscopy is 10 years later. So it would really buy you 10 years, of time before you meet your next scope. Okay, so the last part of this talk is talking about just a little bit about treatment. And again, we go back to stage, because stage not only affects the outcome, but it affects the treatment of the cancer. So again, the T stage, again, depends on how thick or how much of the cancer has grown out of the intestinal wall. So this is T1, T2, T3, and T4. And then the nodal status, again, the end stage is determined by how many lymph nodes around the colon are affected. We also use X-rays as well as CT scans and PET scans to help us to determine whether there's any spread elsewhere. And in this case, you can see very unfortunately, there are a lot of dots or black marks inside the liver, and this is very suspicious. If there is a patient with colon cancer, this is very suspicious of spread to the liver. In this case, this is a CT scan of the lungs, and again, you can see these white growths, and this is again very suspicious of spread to the lungs. And then in this PET scan, we can see that there's a light up in these areas, and these are probably lymph nodes. This CT scan is showing probably what we call peritoneal metastasis, because you can see that outside of the intestine, there's a lot of haziness, and that is likely to be spread into the peritoneum. We don't usually do MRI scans for colon cancers. However, for rectal cancers, which is the lower part of your large intestine, MRI scan is part of the staging process. And what it allows us to see is very clearly the rectum as well as the surrounding lymph nodes. And if you see like this is the lymph node, or if you see that the tumor in the rectum is very bulky, some of these patients would benefit from some kind of treatment before surgery, like radiation or chemotherapy. Understanding again the metastasis and where it spreads is also important. And similar to stomach cancers, colorectal cancers either spreads to the lymph nodes that are around the colon, or they tend to spread to lymph nodes, other parts of the body, or to the liver and lung. And again, it can affect the peritoneum. Again, you see this table here that shows that the survival rate really drastically drops if you have different stage, higher stage of colon cancer. So in the localized early stage colon cancer, the 5-year survival rate is 90%. And if you remember with stomach cancers, that was 70%. So even if you compare early stage stomach cancers versus colon cancers, stomach cancers tend to be worse. But in colon cancers, if you have distant spread or stage 4 disease, the 5-year survival rate is slightly better than in stomach cancers, but still much lower than if you had early disease. And it is very similar for rectal cancers as well. So early stage cancers can be cured by surgery alone. Sometimes if the lymph nodes are involved, then patients would usually have surgery and then chemotherapy after. However, in patients who have very advanced or metastatic cancers who have spread elsewhere, these patients are usually not suitable for curative treatment. However, there are some selected cases if they have certain conditions. We can consider performing surgery to remove the spread and potentially cure these patients. But that's probably a bit too much for this talk at this point in time. So I think my last slide is really to just summarize everything up. And I think after listening to all these two talks about stomach cancers as well as colon cancers, you might be thinking, oh no, what can we do? If you have the risk factors, you might be a higher chance of getting these cancers. But if you don't have risk factors, you can also get these cancers. So what can we do? So I think there are very simple steps that we can take. I think the first is really being aware of your symptoms and of the symptoms that stomach and colon cancers can have. Knowing them and looking out for them is the first step. And I think being very aware of your own bowel habits and if any changes occur, to seek medical attention early rather than to delay. And so that's important. I think the other thing is that depending on your age, you might want to consider screening, even though you might feel really healthy. Sometimes we never know, and doing a simple screening procedure with endoscopy or with a blood test may be what saves you. And lastly, healthy living is also easy and also I think makes a big difference. Maintaining a good weight, having lots of fiber as well as vegetables in your diet has been shown to reduce your risk of all types of cancers. And lastly, not smoking and taking alcohol in moderation.